All right, well, as folks are joining here, I just wanted to welcome everyone to today's webinar, Optimizing Outcomes in Aortic Stenosis, the Case for Early Action. My name is Shana Costello, and we're thrilled to be here with all of you as we dive into an important discussion on aortic stenosis patients. So just a couple of quick housekeeping items before we begin. Please note that this meeting is being recorded, and the recording will be emailed to all registered participants. Also, please remain on mute unless you're asking a question. Questions should be held until the designated Q&A time. We recommend that you submit your questions in the chat to be addressed during the Q&A. We've gathered an incredible group of experts to explore early treatment for asymptomatic patients. Our goal today is to review current guidelines and recent evidence for early treatment, review some varying patient cases, and foster a meaningful speaker discussion on the impact of clinical practice. So before we begin, I'd like to extend a special thank you to our speakers. We have three of them. The first is Dr. Martin Leon, the Mala Family Professor of Cardiology, Chief Innovations Officer and Director of the Cardiovascular Data Science Center at Columbia Interventional Cardiology Care at Columbia University Medical Center, and the founder and chairman emeritus of the Cardiovascular Research Foundation. Dr. Leon is also a member of the AHA's Target Aortic Stenosis Scientific Advisory Group. Dr. Philippe Genereux, Director of the Structural Heart Program at Morristown Medical Center and esteemed researcher, including the principal investigator of the early TAVR trial. And Dr. Linda Gillam is the Dorothy and Lloyd Huck Chair of the Department of Cardiovascular Medicine, the Medical Director of the Cardiovascular Service Line at Morristown Medical Center, and a Professor of Medicine at the Sidney Kimmel Medical College at Thomas Jefferson University. And Dr. Gillam is also a member of the AHA's Target AS Scientific Advisory Group. We appreciate them sharing their expertise, and to all of you for taking the time to join us today. Your engagement and perspectives make these discussions truly impactful. And so with that, let's get started. I'd like to welcome our first speaker, Dr. Leon, who will review the current TAVR guidelines. So Dr. Leon, the floor is yours.
Shana, thank you very much, and I'm really delighted to be here on behalf of the AHA and the Target AS program. Importantly, I've been a practicing cardiologist, interventionalist, and structuralist for the past 40 years with an obsessed interest in aortic stenosis. So a lot of the things we're going to discuss today are really clinically relevant topics, and it's essential that we create this dialogue so that we are best treating our patients in 2025. To kick things off, I'm going to talk a little bit about the current guidelines. Now, these guidelines were published as a focused update in 2020, just over 5 years ago, first authored by Catherine Otto, an esteemed cardiologist who's very familiar with guidelines. And these are the current guidelines relating to severe asymptomatic aortic stenosis. That patients be followed every 6 to 12 months for the presence of symptoms, and those symptoms can be either spontaneous, which would be a class 1 indication, level of evidence A for an aortic valve replacement, or they should be followed with an exercise test. And if an exercise test indicates symptoms during exercise, that's also a class 1 indication, level of evidence A. If the patient remains asymptomatic during follow-up, there are still 1 class A and 5 class 2A or B indications for treatment with AVR. The class 1 indication, if a patient remains asymptomatic, is a left ventricular ejection fraction of less than 50%. This is level of evidence B in non-randomized data. There's also a recommendation for a positive stress test as denoted by a decreased exercise tolerance, a little bit vague, or a greater than 10 millimeter decrease in systolic blood pressure during exercise. This is also a class 2A recommendation, level of evidence B, again, non-randomized data. If you have severe aortic stenosis, not simply severe, but very severe, meaning a peak velocity of greater than 5 meters per second, that's also a class 2A recommendation for AVR in an asymptomatic patient, level of evidence B, and that's based upon some randomized data, largely in surgical studies. If the peak velocity progresses very rapidly with a greater than 0.3 meters per second per year change, that is also a class 2A indication. And if you have a BNP that's greater than 3 times normal, that's similarly a class 2A recommendation. These are both level of evidence B, non-randomized data. And finally, if you have a left ventricular ejection fraction less than 60%, not 50%, on 3 consecutive measurements, that is also most recently a class 2B recommendation, level of evidence B, again, non-randomized data. So we do have an interesting group of recommendations for following severe asymptomatic aortic stenosis based upon the current guidelines.
All right, thank you so much for that review of the guidelines, Dr. Leon. And moving along to our next topic, Dr. Genereux is going to review current evidence for early treatment of asymptomatic aortic stenosis patients. So Dr. Genereux, the floor is yours.
Well, first of all, thank you so much for the kind invitation. And it's really my pleasure to be with two of my, I would say, life mentor, Dr. Leon and Dr. Gillam and friends. Today, what I'm going to do, I'm going to review the current evidence, obviously the recently published early TAVR trial, but also 3 other trials that were previously published, and try to extract what the key message and the lesson that we learn from those 4 trials, and we can apply and in practice, and potentially will change the guideline that Dr. Leon just mentioned. So first, we're going to talk about the largest recent randomized trial that was published. Obviously, I was lucky to be the principal investigator, and Dr. Marty Leon was the chairman of the trial, the early TAVR trial. The early TAVR trial was a large prospective randomized controlled trial that evaluated patients with asymptomatic CVRAS, age of 65 or higher, with an SKS score of 10% or less, and an LVEF 50% or more. Each patient in the trial were asymptomatic, confirmed by a negative low-level stress test. Patients were randomized after a CT scan was performed to confirm the suitability for transfemoral TAVR with balloon expandable valve. So patients were randomized 1-for-1 to either transfemoral TAVR with the balloon expandable SAPIEN 3 or SAPIEN 3 Ultra, to clinical surveillance, which was defined as an echocardiogram and clinical surveillance every year. The primary endpoint was for superiority and was a non-hierarchical composite all-cause death, any stroke, or unplanned cardiovascular hospitalization at a minimum follow-up of 2 years. So to enroll 901 patients, we had to screen 1,578 patients between March 2017 and December 2021. And I will say the first 2 lessons that are very important from the trial is 42.9% were excluded. And from the patients that were excluded, 20%, so 300 patients, 20% already had a class 1 indication for AVR. And remember, those patients were sent to us for inclusion and were deemed asymptomatic, having CVRS with no symptom, and they were referred, after further review, they already have 20% already had a class 1 indication for AVR. Also, 15%, 1 out of 6, did not have a suitable anatomy for TF-TAVR and were probably more suitable for surgery. So those key lessons are important. From them, 901 patients were randomized 1-to-1 to either transfemoral TAVR and or clinical surveillance. So this is the baseline characteristic. As you can see, the mean age was 76. So really, I would say a TAVR population, so elderly population. 30% were female. 83% approximately were assessed as being low risk for surgical AVR by the heart team. So 15% were considered high risk or intermediate risk. More than 90% had a low level negative treadmill stress test. So 10% were included in a trial because they could not do a stress test for orthopedic issue or other reason. The key CCQ score was extremely high. As you can see, 93% key CCQ score, which is extremely high and really underline a very asymptomatic and well population. Bicuspid were allowed, so 9% approximately of the patient were a bicuspid. They were suitable for TAVR. In terms of the primary endpoint of death, stroke, and unplanned cardiovascular hospitalization, early TAVR was associated with a 50% reduction in the primary endpoint. And you can see the rate at up to a median follow-up of 3.8 years, with a number needed to treat of 6 patients at 2 years to save 1 event. So early TAVR was deemed to be superior to clinical surveillance in patients with severe AS and no symptoms. Put in proportion, you see the primary endpoint was at 3.8 years median follow-up, 26.8% versus 45.3% in favor of early TAVR. There's no significant difference in mortality, and we will discuss about that. A finding that was very, I would say, both surprising and important was the trend to a decrease and a lower rate of stroke with early TAVR strategy compared to clinical surveillance, and the rate of stroke was continued to accrue through time in the clinical surveillance. And obviously, the primary endpoint was dominated by a benefit of early TAVR in terms of unplanned cardiovascular hospitalization compared to clinical surveillance. One of the key findings of the early TAVR trial and probably explain the lack of benefit and mortality is the readiness and the promptness of treatment in both groups. As you can see, if you were randomized to early TAVR, the median timing to receive your TAVR was 14 days, which just underline how ready the patient were. They already had their screening, they already had their CAT scan. The procedure readiness was very exceptional. On the other hand, if you were randomized to clinical surveillance and you had an indication for AVR, you developed symptom, the median time to AVR was 32 days, with 90% of the patient approximately who converted to AVR were treated within 3 months of AVR. And this is very important finding because this is extremely prompt treatment. And I think we could say that if we apply the rule of target AS, which means to be treated within 3 months of symptom, we can probably mitigate mortality. So I think this is another great lesson of early TAVR. Interesting question is, could those results be extrapolated in real world? And we're going to have the chance to discuss about that. Another very important findings is we had an exploratory endpoint of death, stroke, and hospitalization for heart failure, which I would say this is an endpoint that resonate maybe easier to understand than the elected primary endpoint of the trial. So when we look at the composite of death, stroke, and hospitalization for heart failure, which actually was defined as IV diuresis, need for IV diuresis, inotrope therapy, intraballoon pump, ventilation for pulmonary edema or hemodialysis, we had a 40% reduction in favor of the early TAVR compared to clinical surveillance. So when we only consider death, stroke, or hospitalization for heart failure, there's a strong benefit as well in favor of early TAVR. I would say the third finding that was extremely important also is the description of the natural history of patient with in clinical surveillance group. When we look at the signs and symptoms at the time of conversion to AVR, we can see that 26% require AVR within 6 months. 47.2% require AVR within 12 months, and 71.4% require AVR within 2 years. When we look at the type of symptom that patient had, you can see that 40% of the patient present with advanced or acute sign and symptom that we can describe as acute valve syndrome. 60% of the patient present with, I will say, milder symptom, a New York Heart Association 2 out of 4, for example. And only 1 to 2% of patients underwent AVR, were still asymptomatic, and 9 of those patients actually all had class 2A or 2B with either very high peak velocity, the need for orthopedic surgery, or urgent cancer surgery. So, and the important point is the proportion of patients who present with advanced and severe sign and symptom through time was consistent. 40% within 0 to 6 months converge with acute valve syndrome, 40% approximately within 6 to 12 months, and et cetera, et cetera. So this proportion of severe symptom at time of conversion was consistent. We're going to talk now about other trials. So we also perform a systematic review and meta-analysis of all the trials available that was just published in JACC, I would say 2 weeks ago. And this meta-analysis include, yes, early TAVR, which include 901 patients, but also the EVOLVE trial from UK, from Mark Dweck and colleague, the AVATAR trial by Marko Banovic from Serbia with 157 patients, and also the recovery trial from Korea with 145 patients. Importantly, the AVATAR trial and the recovery trial include only surgical AVR as a treatment group. The EVOLVE trial, 80% of the patients were treated with surgery, and early TAVR was only TAVR. So we have a good mix of therapy and patient population. Also very interesting, we have a wide distribution in age. The AVATAR and recovery trial include patients from 18 years old and above. The mean age was 65 years old approximately, and most of the patients, 50% were bicuspid, and also 50% receive mechanical valve. And you can see the severity of those AS. The recovery trial was a peak velocity and mean of 5.1, which is critical. And Banovic and AVATAR and all was 4.5, which is severe. And you can see that EVOLVE and early TAVR was more around 4 to 4.5. So really a wide range of age and also a wide range of severity of AS for the totality of the evidence. And what we demonstrate when we pull all those patients together, approximately 1,400 patients, we see that we have a trend in reduction of mortality that was non-significant. We have a trend in the reduction of cardiovascular mortality, but that's also non-significant. But clearly, early intervention, whether IVR or early TAVR, decreased by more than 70% heart failure hospitalization, by 60% unplanned cardiovascular hospitalization, and again, surprisingly, by 40% the risk of stroke. So I think the totality of the evidence is very important to put things in perspective, and also, I'm sure we're going to discuss for the elaboration potentially of the new guideline. So when we look at this, the totality of the evidence and the conclusion of the meta-analysis is the benefits of early AVR, whether TAVR or surgical AVR, is really in regard of the reduction of heart failure hospitalization, unplanned cardiovascular hospitalization, and stroke. And this finding really support and represent an argument in favor of early intervention. Also, we also see that there was a lack of harm in the early intervention across the board of those 4 trials, and really highlight the benefit of a less invasive approach, but also prompt conversion to treatment in all the trial. Is really highlight the outcome of patient in clinical surveillance is really dependent on the quality of the clinical surveillance, which was exceptional in early TAVR. I will say maybe more real life in the other 3 trials. So now I'm going to try to illustrate and put some color with patient example. They were all 3 patients from the early TAVR trial randomized to the clinical surveillance, and just take through their journey of how they convert and land in the symptomatic zone. So the first patient was randomized to clinical surveillance, 80 years old male, obviously with severe aortic stenosis with no symptom, confirmed by stress test, hypertension and anemia. You see the echo. You can see peak velocity of 4.4, mean gradient of 46 with AVF 0.85, normal EF at 55%. Key CCQ score extremely high, 96 point, and patient has an STS of 1.4. Patient randomized in the clinical surveillance arm of early TAVR. Over the course of the first 10 months, patient have become progressively more fatigued. An echocardiogram was done and show a mean gradient of 57, which is progressed with EF that drop at 44%. And the patient came actually in the hospital for a first degree AV block and fatigue and a drop of EF. Within 28 days of this drop of EF, the patient received a TAVR, converted to TAVR with no death, no stroke. And the patient was counted as an unplanned cardiovascular hospitalization per se. The second example is also very interesting. So 73 years old male with severe aortic stenosis, negative low-level stress test. You see a little bit more severe aortic stenosis, mean gradient of 57, peak velocity of 4.7, AV 0.7, and an EF very normal at 70.7, 71%. Patient extremely, in spite of the severity of AS, patient has a key CCQ score almost perfect of 98, so very asymptomatic patient. Patient also randomized to clinical surveillance, and when you see his evolution was pretty surprising. In spite of having a very low KCCQ score and negative low-level stress test, patients start to be dizzy and had a syncopal episode within a month of randomization. As a matter of fact, 19 days after being randomized. Patient got reassured, but also had a second episode while shopping, and subsequently developed VTRS in an ambulance en route to the hospital. EF was preserved, the mean gradient was 56, and thankfully the patient underwent an uneventful TAVR at 84 days with no mortality, no stroke, but was counted as unplanned cardiovascular hospitalization. The case 3 also interesting. So 87 years old male with severe aortic stenosis had prior bypass with a Lima to LAD, some sort of peripheral vascular disease as well, had a negative low-level stress test. STS was intermediate risk at 3.5. Also, in spite of all the advanced age and all the disease, was pretty asymptomatic with a key CCQ score of 98.6. Was randomized to the early TAVR trial after confirmation of suitability for TF TAVR. Patient was admitted with acute decompensational heart failure. So after 2 months of randomization, patients start to develop more fatigue and dyspnea, get hospitalized with acute pulmonary edema with acute heart failure, and all of a sudden the LVEF decreased to 30 to 35%. The BNP was 1650 and it required oxygen and almost ventilation. He was elected to do an urgent balloon valvuloplasty to temporize the symptom and stabilize the patient. And the patient received his TAVR in the same admission. 76 days, less than 3 months after randomization, and hopefully no mortality, no stroke, and what was counted as an unplanned cardiovascular hospitalization. So I hope those 3 cases really give some color of how patient converted, different mode of conversion, some a little bit more soft, some a little bit more violent, but I think it's give you the spectrum of how patient in time converts, some early, some very early, and some a little bit later. So I'm going to stop here, and I think Dr. Gillam will moderate the discussion.
Yep. Thank you so much, Dr. Genereux. We are going to switch gears. And so for the next 15 minutes, we are going to have an engaging discussion of all 3 of our speakers moderated by Dr. Gillam. So Dr. Gillam, yes, please take it away.
Yeah, so I think we learned a lot from Philippe's presentations, plural, and from Marty's review of the current guidelines. So in this next 15 minutes, I'm going to jump in with what lessons did we learn from the randomized trials that Philippe shared with us, and how do we translate them into the real world? So I am a clinical cardiologist who, like Marty, has had a career-long interest in valvular heart disease as both an imager and as a non-invasive cardiologist. So from the perspective, I think, of a non-invasive cardiologist, some of the most important lessons learned, and I'm going to amplify comments that Philippe has already made, have to do with this issue of symptom status. So we kind of like to think that if we ask the patient and maybe those accompanying them to visits, do you have, and we have our list of symptoms that we query them on, that will identify patients who are symptomatic and who really have class 1 indication for intervention. But as Philippe pointed out, even in a highly selected group of patients whose referring cardiologist had referred them for consideration of participation in early TAVR, over 300 of them were identified as having symptoms, many of them through formal stress testing. Stress testing carries a 2A indication in these patients, but we know that frequently stress testing is not performed. So that's to me one very important take home. The other thing is that there isn't really a warranty. If you see a patient on day 1, despite the fact that the guidelines give us 6 to 12 months to routinely bring them back for echocardiographic follow-up to talk to the patient, we saw from the early TAVR data that patients got into trouble. And moreover, even though and we do see this, we like to think that the onset of symptoms is insidious, but it isn't always insidious. As Philippe pointed out, a number of these patients, again, watched carefully, these were patients who had been reminded what symptoms to be on the lookout for. But when those patients presented, some of them had really crashed and burned, so to speak, syncope, cardiac arrest. This is not, and all within what would have been the period that you might have just sent the patient home and said, I'll see you in 6 to 12 months. So those are the big lessons learned that I took away from these trials as a non-invasive cardiologist, but with two very experienced clinical cardiologists and interventional cardiologists. What would you add to that list? And maybe Marty, do you want to lead off? Oh, you're muted.
Linda, thanks very much. I think you've clarified things for many of us. To me, this trial was extremely revealing. I want to tell you, it's difficult to do these clinical trials. As Philippe will emphasize, it took 7 years to develop the trial, enroll the patients, follow the patients, and we're dealing with almost 1,000 patients. So this trial is the only one that exclusively used a less invasive AVR technique, TAVR, in obviously pretty low-risk patients. We're talking about patients that were exercise test confirmed more than 90% of the time as being truly asymptomatic, who had baseline KCCQ scores above 90, which is truly asymptomatic. So it was a rarefied population of asymptomatic severe AS patients. Now, patients are motivated in a clinical trial. Investigators are motivated to follow them closely in the clinical trial. During the course of the enrollment process, we got CT scans in everyone to see if they were candidates for TAVR. So there was a readiness factor to be able to move on briskly with an AVR if symptoms did appear. So this is a little bit different than what we see in the real world. And it's not uncommon to see results that reflect more of this rarefied, rigorous environment of being in a clinical trial relative to what is a more real world or non overly scrutinized patient population. Even though we say that these patients have clinical surveillance, there are two kinds of clinical surveillance. There's passive surveillance, where you say, well, give me a call if you have any symptoms, or I'll see you in a year. Or there's very active surveillance, where you're alerted to the patient, where you're connecting with them much more frequently, and where the follow-up is not at a year, but frankly, at the very longest, 6 months. And many times, I think, physicians would want to follow even more closely the severe AS patients. So we learned from this study that a very active surveillance approach, which was adopted in the early TAVR trial, really does uncover symptoms at a much earlier stage in truly asymptomatic patients. So there isn't very much value in waiting very long in these patients, because, as you saw, half of them at a year had already presented with symptoms with this active surveillance. The second thing that we learned, and Linda pointed this out, and Philippe did as well, was that the promptness of treatment makes a big difference. And the readiness factor of having screened these patients, getting CT scans, communicating with their referring doctors and with the patients themselves, that if they develop symptoms, that the intent was to move ahead very quickly with AVR, we think contributed to the very good results in the clinical surveillance arm, and was probably one of the reasons why we didn't see a benefit in mortality, because there was such prompt conversion to TAVR, and the results of TAVR in these patients were so good with the less invasive therapy. And then lastly, we learned that this mode of presentation is not what we had expected. We had in our minds the concept that the progression of AS from a asymptomatic to a symptomatic state would be predictable, would be a continuum from no symptoms to very mild symptoms, and then it would be mild. It would be significant enough to actually alert the patient to communicate with their physician. But the reality is, 40% of the time, and very unpredictably, the mode of symptom presentation was not predictable and progressing to class 2 symptoms, but progressing to 3 and 4 class symptoms. And many times, as Linda said, this crash and burn scenario. We now have created a term for that, and that term is acute valve syndrome, which, much like acute coronary syndrome, should have different connotations and probably does importantly predict what the optimal outcomes will be in that population if left untreated for very long. So we learned a lot about the natural history of asymptomatic severe aortic stenosis, and we also learned that more active surveillance, readiness to therapy, and prompt treatment is required to achieve the optimal results that were obtained in the early TAVR trial.
Yeah, thanks for those comments. And Philippe, what would you like to add to that?
I think you both elegantly summarize the early TAVR trial major finding. One thing I really like, and I'm proud actually from the early TAVR site and PI, and is really that the clinical surveillance was optimal, and we did the clinical surveillance the way the guideline envision it. So if you have symptom, you promptly intervene. And we also apply the clinical surveillance the way Target AS Initiative envision, meaning that if you do AVR within 3 months of symptoms, you will potentially mitigate mortality, which is extremely good news for clinician and patient. And then I think the meta-analysis gave us the other side of the medal, with the AVATAR and recovery trial showing a benefit of mortality of early intervention with clinical surveillance and waiting time when you convert to symptom of 6 up to 12 months. So when we look at the totality of the evidence, early TAVR and AVATAR and recovery really support a prompt treatment as soon as symptoms occur within 3 months, which is literally the Target AS Initiative. And actually, the natural history of all those trials showed that by 1 year, you have 50% of the patient that will need AVR, and 40% would come in acute valve syndrome. So why do you want to wait to the symptoms? So I think the totality of evidence is very important, because those 3 other trials show you other side of the medal, and the side effect and the vicious effect of waiting too long while symptom. And there's a lot of geographies such as Canada and UK and France and Australia that have a system where they don't have access to care easily. And this is an argument, even more importantly, to plan carefully in a civilized way in advance your treatment. And there's a question in the chat that say, if TAVR is scheduled in advance selectively, what can we do to optimize those patients? Well, I think we show in early TAVR that if you have a CAT scan in advance, if you have, for example, dental clearance in advance, and you talk to the patient, the referring say, as soon as you get symptom, you come, this is where we're gonna decrease mortality of a disease of aortic stenosis in the general population. And I think we're getting there. So I think I'm very proud of early TAVR because we will never be criticized of having benefit because the clinical surveillance was not optimal. So that's for sure.
Well, so many lessons learned. So just in the interest of time, I think people on this webinar want us to try to address questions 2 and 3. Let's start off with, what should I tell the referring physicians? Marty.
Well, again, I would be very aggressive with referring doctors that severe aortic stenosis, symptomatic, obviously, they should be treated promptly with AVR. Asymptomatic, we do believe that a low-level stress test is important to be able to discern whether or not they truly are asymptomatic. And there should be an alert to readiness for treatment. And that alert is, as Philippe just said, a CT scan to understand what the treatment options are, dental clearance to be certain that you can move quickly with management of these patients if they do develop symptoms. And the physicians really need to be alerted to this active surveillance concept. And I don't think you should wait a year to connect with these patients. We think, the guidelines are a little bit vague. They say 6 months to a year. I would never wait more than 6 months to be able to connect directly with these patients to be certain that they are not developing earliest and more insidious symptoms. Because remember, it's an elderly population. Many of them are not going to communicate early level symptoms unless they're prompted. So I think this active surveillance, is very important to convey to physicians.
And I would say, Linda, if I can summarize in one sentence, is really early referral for timely AVR. And this is what we need to avoid, is to do everything, all the tests 2 days before the TAVR, which is suboptimal. So early referral, as soon as you have severe AS, with or without symptom, you refer, you plan accordingly, early procedure planning, a timely AVR.
Yeah, and I would just amplify that early referral to the valve program, and a conversation with your patients. I think that this is although they feel well, and yes, you're going to see whether they're actually doing as well as they think they're doing. This is a dangerous disease. So they have to get into a mindset that something is going to need to be done, not it's going to be on the back burner and I'll see you in a year. So it's a conversation, I think, with patients, which sort of takes us to our next questions. What should the message to patients be? And I've already shared that I think it's mostly about preparing them for the need for an intervention at some point, the need to be hyper alert to any symptoms. And I would sort of add to that this message should go to family members as well. So when I see these patients, I encourage them to bring family members, and I'm not infrequently struck by the fact that the patient will say they're doing fine. And even at that first visit, asymptomatic AS, the family members are very clear that there's been a deterioration in the patient's functional capacity. But what other comments about messaging to the patients?
Yeah, I think, Linda, you said it exactly the way that I would describe what this scenario should be. People tend to forget that The first partner trial that we did, the Partner 1B study, in very high-risk patients using a very early prototype device, often with transapical implantation techniques, nothing close to what we currently have available, but still 50% of the patients who were not treated and had standard therapy were not alive at a year. A 50% one-year mortality. It more than recapitulated the original Brown-Wall curves. And I must tell you, this is a very insidious and very dangerous disease. So patients shouldn't be frightened, but they should be ready to understand that if they have severe aortic stenosis, there's a high likelihood that they're going to develop symptoms, that we want to identify them as early as possible. We want to prepare them for the likelihood of having an aortic valve replacement, and that when symptoms appear, they should understand that the promptness to therapy is going to affect their optimal outcomes. So all of those messages sometimes get lost in the shuffle, and it's difficult if you're a practicing cardiologist. You have so many patients to see. The sophistication required to get CT scans, to interpret those CT scans, and to do some of the other things that might be done in a more experienced valve clinic environment make it difficult to achieve this active surveillance approach. So I agree with Linda. If you've got a severe AS patient, asymptomatic, I would refer those patients to a center of excellence that has valve clinic capabilities to be able to watch these patients more closely.
Yeah, and I think the other part of the message is, yes, this is a bad disease, but we have an amazing treatment for this disease. Devices that are currently perform extraordinarily well, but with improvements almost day by day. I'm going to shift, just in the interest of time, to the last question. How do you explain the reduction in stroke observed with early intervention compared to delayed intervention? I'm going to lob this one to Philippe.
So thank you, Linda, for providing those questions. And I have to say that this question of a trend to reduction in stroke with early intervention is, when I saw the data for the first time, and we were all together, it's the first thing that really shocked me, and I was so surprised. And when we designed the trial in 2015, initially the assumption was we're going to have a benefit of 15%, potentially, mainly driven by heart failure. And we designed the trial with the assumption that it will be difficult to have a mortality benefit with a very, very asymptomatic, truly asymptomatic population with great follow-up. And actually, we factor in potentially an increase in stroke, at least early, with early TAVR group, because obviously we do a therapy. We have 455 patients that we do TAVR. So of course, I counted at 0.5% and 1% more stroke initially, and that will partially equalize through time. What we saw was the opposite. We saw that actually the stroke was extremely low in both group, 0.9% in early TAVR and 1.8% in delayed TAVR. But what we saw is the clinical surveillance group accumulate stroke through time while waiting, and also after the delay AVR. So for me, when I saw that, it was a 40% reduction of stroke with the early TAVR. And I would say for me, it's pushed me to think, and there's probably multiple reasons. The first one is, I believe aortic stenosis is a risk factor for stroke by itself. When I look at the calcium score of the patient at baseline early TAVR, and I look at the calcium score in 2 years, there's some cases where the calcium score double, triple. 1,000 calcium score at baseline, 4,000 at time of conversion. So I believe there's some sort of shedding of the valve potentially, and this is all hypothesis that might be verified in the future. I think AS may be a risk factor for stroke. Second, probably under-detected atrial fibrillation. We didn't do loop metering in early TAVR. We just did an ECG every year. Potentially the LA enlarged, and we saw that in the cardiac damage sub-analysis where the LA enlarged with clinical surveillance, maybe more AFib that are undetected. Maybe we have to be more aggressive with AFib detection. Third reason is potentially with more calcium score on the valve, with a more crash and burn scenario when we were in a rush to do the procedural outcome are less optimal. And we saw that at a 30-day result with a stroke rated post-delay AVR was 1.8% compared to 0.9%. So, and the last is what we call the acute valve syndrome. When you crash and burn, you're more inflamed, you're more inflammatory, you probably are more bleeding risk. And all those 4 factors make me think that we have a lot to learn in terms of aortic stenosis as a potentially thrombogenic factor for stroke, a risk factor for stroke, either during the waiting period or also at the time of intervention. So for me, it was a fascinating finding. It's very hard for me to sleep on this because actually there's 40% reduction in stroke. And I will say we do Watchman procedure where they don't even reduce stroke, and it's all for bleeding prevention. And here we are with 40% reduction with early intervention, which for me, I believe deserve more study to see if this is a real finding.
Yeah, so thank you. I think, one of the hallmarks of the most impactful trials is I think that they're hypothesis generating, and this particular dimension of early TAVR and other issues that have come up in the discussion, I think remind us that there are still a lot of questions that we need to try to answer. So I just want to thank Marty and Philippe for what I hope you will agree was really a terrific discussion. And we will move on to the next segment of this webinar.
Yes, thank you so much for that really insightful discussion, Drs. Gillam, Leon, and Genereux. We're going to now hear from my colleague, Sarah O'Kane. She's the Senior Product Development Manager at the American Heart Association, and she's going to review how you can use the AHA's Target Aortic Stenosis QI program to identify and track asymptomatic patients. So Sarah, you can take it from here.
Thank you, Shana. All right, I think we can go to the first slide. So I know we've been talking about the Target Aortic Stenosis Quality Initiative a lot, but haven't totally explained the mission and how it works. But the AHA entered the aortic stenosis quality space really in earnest starting in 2019 through the Target AS Quality Initiative. And the initiative is really laser focused on the pre-procedural processes affecting AS care, namely appropriately diagnosing if a patient has moderate or severe AS, referring them for AVR when indicated, and then getting patients treated in a timely manner. So to best help health systems identify exactly where their current processes are working or maybe falling a little bit short, we have the registry and the platform associated with the registry. So health systems enter a sample of AS patients on a quarterly basis, and then they continue to follow these patients until they either receive treatment, which could be AVR, or it could be non-procedural treatment if that's the final decision, or until their care is discontinued. And so with all the data points that we collect around this care journey, we're able to provide health systems several key metrics that directly measure whether or not things like their echo reports are containing all the necessary data to make decisions, whether diagnostic assessments are happening in a timely manner, and whether treatment is being achieved in the timely manner to optimize outcomes. So in addition to the platform and the data, registry participants also have access to peer learning collaboratives to hear from other organizations who are trying to improve the same things, as well as our quality consultant team who reviews data one-on-one with health systems and can help support those improvement efforts. So going into the actual registry itself, the beauty of it is that as emerging evidence like the early TAVR trial comes out, we have the ability to provide immediate data on the patient cohorts that are kind of newly of interest in the scientific space. We already collect data per patient to identify if they exhibit AS symptoms or not, as well as when those symptoms develop, and the echo measurements needed to identify severe AS. So for this particular trial, we're already pretty well poised to provide data on this patient cohort. So I wanted to quickly walk through how Target AS users can use the registry platform to review their asymptomatic patients that are already in the registry. So for users who have access to the platform, we have an operational report section. And then within this, we have our fixed period measure reports. For this particular example, I'm just having us select the 2024 measurement year, since that's just the most recent year, and that's where most sites have just been finishing up data. But obviously, if we're in a future year, then that time period would change. And then my next suggestion would be to select our AHA-AS01 metric, which is the timely treatment for severe aortic stenosis metric, which is technically focused on class 1 indicated patients, but the case list that comes with the measure is much broader, so that is why I recommend using it for this purpose. Now, once the report generates, you can get to the patient case list to do some kind of initial data digging. So to do this, you're going to click on any cell in the measure details row where I have that yellow number 1. Once it highlights blue, then you can select the patient case list, which is where that number 2 little bubble is. And then with the registry results that you get, you'll get a patient list and a case list. But for this particular exercise, we would want to just use the case list because it provides the most detail. So the case list for this measure is useful because it includes all patients with a potentially severe echo from October of the prior year to December of the selected year. So it's about a 15-month period of patients with a potentially severe echo. And then in the case list, we have several columns that can give you a clear indicator of a patient's symptom status, as well as other details. They appear simple. It says, are they AS stage 1, stage C1, are they stage C2? But there's a lot going into those columns behind the scenes to calculate using all the data points we get if a patient qualifies and what's their earliest qualifying date. So the key columns that I would use for this are that earliest asymptomatic date column, the AS stage C1 column, and then AS stage C2. And just to level set on the basis for, sorry, I'm trying to advance the slide, but it's not happening. There it goes. Just to clarify what we mean by asymptomatic in the Target AS registry as you're pulling this data. So a patient in the registry is considered asymptomatic for the purpose of those columns when they've been assessed for AS symptoms, either via an outpatient visit, an inpatient admission, or a treadmill stress test, and they've been confirmed to have no AS-related symptoms. So it can't just be that the abstractor has only ever entered an echo, but nothing else. They don't automatically get counted as asymptomatic. It has to actually be that, a physician saw them and determined no symptoms. That said, I know as part of the trial, all of those patients were confirmed by treadmill stress test to be asymptomatic. This is a little bit of a broader criteria, but it might be worth looking into these patients if they don't have a treadmill stress test, but are otherwise eligible. It might be worth additional assessment. And then lastly, just wanted to give an idea of how I would approach identifying these patient cohorts using the filters we have in the platform and using those columns. So our stage C2 patients, these are the asymptomatic high gradient patients with reduced EF. They're already class 1 indicated, so that's kind of a group we're already measuring, so it might not be of the most interest. The patients with a stage C1 date are the closest we have to the early TAVR trial criteria. These are asymptomatic high gradient patients with an EF that is normal. And so if you see a patient that has a stage C1 date and they have no other AS stage, they haven't progressed to another AS stage, then this would be a good population to focus on. Or if you wanted to just broadly look at any patient who is asymptomatic, regardless of their stage, then I would just use that earliest asymptomatic date column and then make sure that they don't also have a symptom onset date. because otherwise that means that they've become symptomatic and now the asymptomatic context doesn't matter. But that's my recommendation for how to use the platform and kind of some of the functionality that we have available as part of Target AS. And then we're always adding elements, we're always adding metrics as emerging evidence comes out. So on the next slide, we're always looking for additional participants in Target AS. So if anyone is interested, you can use this QR code. And then with that, I will go ahead and pass it back to Shayna.
Well, thank you, Sarah, for that detailed overview. And as shared, if your site is interested in enrolling in Target Aortic Stenosis, please do scan the QR code so that we can gather your information. You can also always email the team at targetaorticstenosis@heart.org. So I know that we only have a few minutes left, and we got a lot of questions about the Target Aortic Stenosis Registry and if it can track this patient population. And yes, of course, as you just saw, it can. So any hospital system team member can review the case list. And now just to get to a couple of questions in the chat for our speakers. How long until you anticipate TAVR becoming available for asymptomatic patients? Who wants to try to take that one?
I mean, obviously, we have now 4 trials that may support guideline change, obviously, in terms of AVR for severe AS no symptom. Whether it's going to be class 1, class 2A, indication remain to be determined. But I think we have a lot of rationale to support early intervention and at least prompt intervention of this indication. I would say that at this point there's a process. There's a process of CMS submission. There's a process of guideline changing. I see that there's a lot of question about the guideline, and this will take probably 6 to 12 months, and we don't know how the guideline will change in the United States. We know in Europe is planned for this year. I don't know if Marty, we have more intel about that.
And just with regards to the ACC/AHA guidelines, there will be an update. They're in the process of identifying people who will be members of the writing group. So there is something in the works. And I'll just remind everybody, if you go back to Marty's slides, there are already indications for asymptomatic patients. They sort of more down in the 2A, 2B range, but just be alert to those. They already exist, and I think they reflect the overall sense of the guideline writing community that that there are other things that we should be paying attention to in terms of deciding when it's time to replace the valve.
Yeah, I would argue that we need to be proactive. Certainly, there's a process for adjusting the guidelines. There's a process for getting CMS to be able to reimburse for that change in guidelines, and that is ongoing. And there's also a submission from the sponsor to see if the indications can be extended for the use of TAVR for this newer indication. So all that I think is ongoing, as has been mentioned at ESC, which is late summer this year. There'll be a revision of the European valve guidelines, and I think they'll take into consideration some of these new trials. We can't predict exactly what it will mean, and I think to follow will be the AHA-ACC guideline adjustment as the committee now begins to structure its evaluation of the current data. So all of this is ongoing, but I would say right now, based upon the data that we've shown you and other data that you'll be hearing, some of it at the ACC, some of it at TCT later in the year, and AHA later in the year, their scientific sessions. I think that you can begin to implement some of the things we've learned into your current practice. This issue of being an active surveillance practitioner managing patients with severe aortic stenosis can be done right now. We don't need to have a guidelines change to be able to tell people that best clinical practice means you have to watch these patients much more carefully, react more quickly, and insist on prompt conversion to AVR once symptoms appear.
Well, thank you. I do want to recognize that we are 1 minute over time, but I just wanted to quickly thank you all for being on with us today, and just a huge thank you to our fantastic speakers. It was truly an honor to have you on today. And we addressed some other questions while the presentations were happening, but if folks have any additional questions, you can always email Target Aortic Stenosis at heart.org. And thank you again for being on today.